Stop scrolling for 1 second. What if the blood pressure reading your doctor waved off as fine is the exact number setting you up for a stroke? And what if the reading that sent them running for a prescription pad was actually nothing to worry about? I know that sounds backwards. But after more than 2 decades treating blood pressure in adults over 60, here's the truth nobody tells you. The number itself isn't the dangerous part. The dangerous part is that almost everyone, patients and doctors alike, is reading it wrong. Let's start with a number that should genuinely worry you. Nearly half of American adults have high blood pressure. Past 60, that jumps to over 70%. 7 out of 10 people your age are walking around with pressure the American Heart Association classifies as elevated or high. But here's what almost nobody explains. Heart attack and stroke risk doesn't switch on at some magic cutoff. It climbs steadily, starting well below the numbers most people think are safe. So the real question isn't, is my blood pressure high? It's too high for me at my age measured correctly? That's what I'm answering today. Stay to the end, and you'll understand your own blood pressure better than most people ever get explained to them in an actual doctor's office. I'm Dr. Claire Brooks. I'm an internal medicine physician, and for more than 20 years, my practice has centered on one thing: the blood pressure of people over 60. I've sat with patients who were terrified because one doctor said their numbers were fine and another said they needed more medication. I've seen people over-medicated to the point of dizziness and people under-medicated and drifting toward a stroke without a clue. None of that is their fault. The guidelines keep changing, and the way most people take their blood pressure at home produces numbers that are, frankly, garbage. By the end of this video, you'll know exactly what counts as too high after 60 based on the largest clinical trials ever run, including the SPRINT trial, which rewrote the rules for treating blood pressure in older adults. I'll show you a number almost no doctor ever mentions, one you can calculate in 5 seconds, that predicts heart attack and stroke risk better than either number on its own. And I'll walk you through the measurement mistakes, quietly giving millions of people false readings. Readings that lead either to medication they don't need or to false reassurance that leaves them dangerously unprotected. If this is useful to you, hit subscribe before you keep watching. It costs nothing, and it's the only reason this reaches the next person who needs it. And because people ask me this constantly in the office, I put everything I walk patients through: blood pressure, blood sugar, memory, balance, all 28 of the things that actually shift as we age, into one place. It's linked below if you want the full picture, not just today's topic. The 2 numbers. You've been half ignoring your blood pressure reading has 2 numbers. Most people only really register one of them. That's mistake number 1, and I've watched it lead to outcomes that were completely avoidable. Systolic. The top number is the force of blood against your artery walls the instant your heart beats. Picture a wave slamming into a seawall. Diastolic, the bottom number, is the pressure between beats when your heart relaxes. Think of it as the tide level when the wave pulls back, the constant baseline pressure your vessels sit in every second of the day. Both matter. After 60, they stop mattering equally. Here's why. Your arteries stiffen with age. Less elasticity, less give. A stiff artery can't absorb the impact of each heartbeat the way a flexible one can, so the systolic number tends to climb. Sometimes that's disease, sometimes it's simply the mechanics of an older artery. Meanwhile, diastolic often holds steady or even drops, because a stiffer artery doesn't recoil as well between beats. That combination, high top number normal or low bottom number, is called isolated systolic hypertension, and it's the single most common form of high blood pressure after 60. If nobody has ever explained that pattern to you, you're not alone. Here's where it gets dangerous. For decades, doctors used a rule of thumb: normal systolic equals 100 plus your age. Under that rule, a 70-year-old reading 170 was fine. That rule was wrong, and it cost lives. We now know sustained systolic pressure of 170 in a 70-year-old sharply raises the risk of stroke, heart failure, kidney damage, and cognitive decline. Then the pendulum swung too far the other way. In 2017, the definition of high blood pressure was lowered to 130/80, and overnight millions of people over 60 who felt completely fine were reclassified as hypertensive. Many started on medication they may not have needed. So, what's actually too high after 60? The clearest answer comes from the SPRINT trial, published in the New England Journal of Medicine in 2015. So, over 9,300 participants, the largest, most rigorous blood pressure treatment trial ever run. It found that pushing systolic below 120 cut heart attack, stroke, and cardiovascular death by 25% compared with the old target of below 140. In adults over 75, the benefit was even bigger, a 33% drop in cardiovascular events. But, and this matters just as much, aggressive treatment brought real risks. More fainting, more electrolyte imbalances, more kidney strain, more falls. In someone over 60, a fall caused by overtreatment can be every bit as dangerous as the blood pressure itself. There is no single number that's too high for every person. It depends on your age, your health, your history, your body. But the research gives us solid ranges. And next, I'm going to hand you those ranges, plus a number almost no doctor calculates that you'll wish someone had told you about years ago. The real ranges and the hidden third number, based on Sprint American Heart Association guidance and 20 plus years treating this age group, ages 60, 75. Below 130 systolic at rest, ideal 130, 139 is acceptable if you feel well. 140, 149 diets, needs monitoring and lifestyle changes. 150 plus consistently at rest, too high, needs action age. 75 plus, below 140 a general goal. 140, 149 hour depends on how you feel and your fall risk. 150 plus consistently, too high regardless of age, diastolic any age. Below 80, ideal, 80, 89, worth watching, 90 plus consistently, real strain on arteries and organs. Now, the number I promised you, pulse pressure. Take 5 seconds, subtract your bottom number from your top number. 150 over 70 gives you a pulse pressure of 80. 130 over 80 gives you 50. Why it matters. Pulse pressure is a direct readout of arterial stiffness. Stiff arteries push systolic up and let diastolic drift down. The gap widens, and that widening gap is one of the clearest cardiovascular warning signs we have in older adults. Data from the Framingham Heart Study found pulse pressure predicted cardiovascular events more accurately than either systolic or diastolic alone in people over 60. Below 40, normal on 40 to 60, acceptable, worth tracking. Above 60, warning sign of significant arterial stiffness and elevated risk. If your reading is 160 over 70, most people fixate on the 160. But the pulse pressure is 90, and that's the number actually screaming at you that your arteries have lost their flexibility. Here's something almost nobody warns you about. Diastolic pressure that's too low can be just as dangerous as pressure that's too high. Research in the Journal of the American College of Cardiology found adults over 60 with diastolic consistently under 60 had meaningfully higher heart attack risk. The pressure between beats simply wasn't enough to keep the heart muscle itself adequately supplied. I had a patient, I'll call him Walter, 74, a retired mechanic, on 3 blood pressure medications. His systolic looked great at 128. Nobody was watching his diastolic, which had quietly dropped to 52. Dizzy every time he stood, 2 falls in a month. He wasn't heading toward a stroke, he was over-medicated. We pulled back 1 medication carefully, and within 3 weeks, his diastolic rose to 68. Dizziness gone, falls gone, blood pressure still controlled. His previous doctor was so locked onto the top number that nobody noticed the bottom had fallen into dangerous territory. Don't just watch the top number. Don't just watch the bottom. Calculate the gap and make sure the bottom hasn't slipped under 60. This is the part that changes the most outcomes, and it's the part almost nobody gets taught properly. These aren't small errors. They can add 20, even 30 points to a reading. That's the difference between walking out reassured and walking out with a prescription you didn't need. Mistake 1. No rest before measuring. Walk in, check in, sit down. Cuff goes on within a minute. Research shows skipping a 5-minute rest inflates systolic by 10, 15 points. Mistake 2. Talking during the reading. Studies show conversation during measurement raises systolic by another 10-15 points. Mistake 3, crossing your legs, adds another 5-8 points. Stack all three and you're 25-35 points above your true number. A completely different diagnosis built on a completely wrong reading. Mistake 4, wrong arm or wrong cuff size. Readings can differ 5-10 points between arms, and a cuff that's too small artificially inflates results. Almost nobody checks this. Mistake 5, white coat hypertension. Anxiety in a medical setting spikes your pressure, even when you don't consciously feel nervous. Adrenaline does it automatically. Meta-analyses estimate this affects 15.30% of people diagnosed with hypertension. Up to 1 in 3 people on treatment may not actually need it. Their pressure only spikes when someone in scrubs is holding the cuff. Here's the protocol I give every patient over 60. 1. Sit quietly for 5 full minutes. Feet flat, back supported, arm at heart level, bladder empty 2. No talking, no phone, no TV 3. Take 2 readings 1 minute apart, record the lower one 4. Do this twice a day, once within 20 minutes of waking, before coffee, once before bed 5. Alternate arms every other day 6. Do this for 7 straight days. 28 readings total 7. Average all 28. That average is your real baseline, not a single rush number from an exam room. If it consistently averages above 150 systolic or 90 diastolic, that's too high and needs attention. If it's 130,149, bring all 28 numbers to your doctor. That data is worth far more than one office reading. When a high reading is an emergency and when it isn't. This is the question I get asked more than any other. When do you call 911 and when do you just sit down and breathe? A high number by itself, even a very high one, is not automatically an emergency. You check your pressure and see 170/95. Panic sets in, but that could easily be a temporary spike from stress, pain, caffeine, or the anxiety of taking the reading in the first place. The difference is symptoms. A high number with no symptoms is a signal to monitor. A high number with symptoms is a signal to act now. Call 911 immediately if your reading is above 180 systolic or above 120 diastolic and you have any of the following: a sudden, severe headache, unlike any you've had before, chest pain or tightness, new or worsening shortness of breath, vision changes, blurring or partial loss, trouble speaking or sudden confusion, numbness or weakness on one side of your body. That combination signals a hypertensive crisis, organ damage happening in real time. Research in circulation puts the 1-year mortality risk from an untreated hypertensive crisis as high as 25%. But if your reading is 170/95 and you feel completely normal, no headache, no chest pain, no vision changes, that's not a crisis, it's an urgency. Sit down, rest 5 minutes, breathe slowly, retake it. In most cases, the number drops 15-25 points within 10 minutes. If it's still elevated after that, call your doctor that day or the next morning. I had a patient, I'll call her Dorothy, 68, a retired school secretary, call my office in a panic, home monitor reading 182/98, car keys already in hand for the ER. I asked 3 questions. Headache? No. Chest pain? No. Vision changes? No. I had her sit, feet up, eyes closed, breathing slowly, for 10 minutes. She called back with a reading of 148/84, still elevated, but well out of crisis range. Her first reading had come right after a heated phone call with her sister. That 182 was never her true pressure. It was adrenaline. She didn't need an ER. She needed 10 minutes and a deep breath. The lesson: we treat patterns, not single spikes. 1 high reading is a data point. 2 weeks of high readings is a pattern that needs treatment. But 180/120 with any of those symptoms? Don't rest and recheck. Call 911. Minutes matter. Bringing it together. Here's what you now know that most people your age have never been told. Your top number tends to rise with age because of arterial stiffness, but a bottom number under 60 is its own danger sign. Ideal ranges: 60-75, below 130 systolic, 75 plus, below 140, diastolic under 80 at any age. Pulse pressure, top minus bottom, predicts risk better than either number alone. Above 60 is a warning. A single high reading isn't a diagnosis. A consistent pattern is 5 common measurement mistakes can inflate your reading by 25, 35 points, and now you know how to avoid every one of them. 180 over 120 plus severe headache, chest pain, vision changes, or one-sided weakness means call 911 immediately. In 20 plus years of practice, the biggest problem I see isn't pressure that's too high. It's patients who don't understand their own numbers, scared of readings they can't interpret, over-medicated from a bad office reading, or under-medicated because their true pressure was never measured properly. Understanding your numbers doesn't create fear. It creates control. Take your reading tonight using the protocol above. Calculate your pulse pressure. Tell me your numbers in the comments. I read all of them. If this gave you real clarity, subscribe, hit like so this reaches the next person who needs it, and send it to someone over 60 who's been quietly worrying about their numbers. It might be the thing that finally makes sense of it for them. And if you want the full picture, I give my own patients, blood pressure, and everything else that shifts after 60 years. It's linked below. I'm Dr. Brooks. Take care of your heart. Everything else depends on it. This video is for educational purposes only and does not constitute medical advice. Talk to your physician before changing any medication or health routine.